Last but not least, the largest medical transplant center in the U.S., Mayo Clinic, Arizona. We have the medical director, Dr. Khamash, who has been the director there for 8 years, probably more than 8 years. I got the pleasure to work with him as a fellow in 2013. At that time, Mayo Clinic was in the top 15, but now it's number 1 in volume. The perspective will not be complete without getting how the practice is happening at Mayo Clinic at the large transplant center. Dr. Khamash, we're very honored to be here.
Thank you. Thank you, Tariq, and congratulations on an excellent program. Tariq was our first fellow to graduate from our program. You really set the bar. I'll tell you, I and the team in Arizona are very proud. Thank you. I'm glad my talk hopefully is going to tie in with Dr. Singh's talk and Dr. Larson's. A lot of the things that got mentioned, we actually do at our program. I have no disclosures. I just want to give highlights on our program. We are one of the largest in the country. We have higher rates of transplant, mainly driven by our acceptance practices, organ acceptance practices. We accept hard-to-place kidneys, be it AKI with CRRT. We do a number of dual adult kidneys for the very high KDPIs. Actually, the paper that was quoted earlier in the talk in the program was from our program. But despite the growth we had, I believe we had maintained good patient and graft outcomes and good patient satisfaction, because is a struggle as you grow. We have a team-based approach, and this is the motto for Mayo Clinic. We try to be as efficient and cost-effective because cost plays the margin for kidney transplant. Again, it boils down to the economics. If it's a losing endeavor, it's not going to be able to grow or continue. So we managed to keep length of stay at 2 to 3 days, safely discharged patients with a DGF rate in deceased donors over 65%. Just a little bit about the program. We have 9 transplant abdominal surgeons, 3 living donor surgeons, 11 transplant nephrologists, about 8 FTEs. Nurse coordinators, we have 10 pre, 4 wait list, 10 post, 4 living donor, 10 procurement that we share with liver and heart, and 2 inpatient coordinators for discharge planning. Advanced practitioners, we have 8 inpatient and 10 outpatient. 8 medical assistants, other support staff, and we have a very robust quality and compliance team that has 3 individuals, an advisor, and 2 RNs, and we have a multidisciplinary adverse event review process that is ongoing. So I'll talk about the challenge. As we grew over the past few years, as you see, we have grown from an average of 200 to 50. Now I think we're on target to do over 500 kidney transplants. And fortunately this year, I'm happy that part of the growth is coming from living donation. So this is also another area that we're putting a lot of effort on right now to grow and advance. But with that increase, comes the challenge. And how do you maintain quality? How do you keep patient satisfaction? How do you keep referring providers happy that they have access to refer patients and be seen on time, and also the transition process after transplant is happening effectively. So that brought up, okay, so where do our patients come from? I think it's important to know where your patients come from, before you make that decision and allocate resources. And our patients, these are over the past few years, transplants in in Arizona, mostly from the state, about 2/3, 1/3 from out of state. And if you look at the out-of-state distribution, mostly from California, Nevada, New Mexico, and Texas. And we wanted to see who's referring to us. It's really important also to know who is sending patients. So Arizona Kidney Disease and Hypertension, it's one of the largest groups in the country, 120 nephrologists. It's based in Arizona, the state of Arizona. They have presence through all the state, and they are our biggest referring group. But we also have the rest of the groups in Arizona, as well as groups from Nevada, New Mexico, and now Kaiser, California. Who are our clientele? Our clientele are the patients, number one, but also our referring providers. And we decided that one size doesn't fit all, and you have to tailor it to the patient's need, as well as the capacity on the referring provider to absorb these patients and care for them. In general, I'll talk a little bit more specifically about special cases, special scenarios. And I want to also confess that everything looks nice on a slide, but this is a work in progress. This is far from being perfect. And I think it's the buy-in from the team and the continued monitoring and keeping the hand on the pulse is absolutely crucial to sustain this as you grow in volume. So we on all patients, all non-local patients, everybody who doesn't live in the Phoenix or the suburbs, we get them repatriated to their primary nephrologist at 5 weeks post transplant. How do we do that? We set the expectations early on with the patient. They get educated about this through evaluation, wait list, and if they have a living donor, the class that they get before they get their living donor kidney, they're told, they all told the same message. But also, we also set the same expectations with the referring providers. This 5 weeks can also vary. We still some groups, they don't want their patients back at 5 weeks. They want their patients back at 4 months or 6 months, and we do accommodate this request because, again, who's our clientele, the patients and the primary nephrologist. So in all non-local patients without complications, we repatriate at 5 weeks post-transplant. Routine labs are done locally, and the primary nephrologist adjusts immunosuppressives. We see all patients, everybody, local and non-local. We see everybody at 4 months, 8 months, 1 year, 2 years, and 3 years. So that gives us, I think that's probably part of the co-management that Dr. Singh talked about, is the patients already with their primary nephrologist. They're doing some of the management, but we also have certain points to touch on the patient, make sure that they don't have a DSA. We do protocol biopsy. They don't have subclinical rejection. We check for BK. We make sure that they take their medicines, and we make sure that they are following with their primary nephrologist. At those visits, we check HLA and surveillance biopsy at 4 months, 1 year, and 2 years. And since COVID, one positive from COVID is the virtual platform, and that has been a godsend for us, as a fair number of our patients are non-local. So do local labs and then see them for a video visit. I mentioned Arizona kidney disease and hypertension is one of our largest referring group. So we do have 3 of their providers who are transplant nephrologists. They are privileged to do outpatient. They come on site. They see their own patients while at the Mayo site. This is for local patients. Non-local patients, they get sent out to their original nephrologist. It does utilize some of our resources, clinic space, as well as lab and coordinator work. But they transition to their own colleagues at about 6 months. Another model is with Kaiser California. With Kaiser California, they have a transplant core group that have several transplant nephrologists. They're able to do biopsies, give thymo, treat rejections. They're fully trained and capable. So we do repatriate these patients at 5 weeks. We don't see them back, but we meet with the Kaiser team every 2 weeks. We review all patients that are in the pipeline, either in the referral evaluation wait list, on site at Mayo or back home with their Kaiser team, and we are available we are always available to take phone calls and consult with their providers. We have a direct line of communication, coordinator to coordinator, as well as physician to physician. Our discharge process from the clinic, we set the expectations early, do it pre-transplant, tell the patients that you will be returning to your primary nephrologist. Back to your question about how do you convince patients, I tell my patients, Dr. So-and-so has my cell phone. If there is a problem, they'll call me, they'll text me. So that, I think, it all down to reassurance and being available also. Nurse coordinator confirms the primary nephrologist and the PCP with each patient and requests appointments early post-transplant. We educate the patient and the caregiver on when to call us, when to get us involved. If there is any hospital admission outside of Mayo, unable to get the medicines or having side effects from the medicines, if they have serious infections or a new diagnosis of cancer, we send a letter to the primary nephrologist, and in complicated cases, we pick up the phone and call the primary nephrologist and talk provider to provider. Other important points that helps us through that transition process is we have an outreach team that keep in touch with the primary offices, to the offices of outside nephrologists, to make sure that referrals are getting in time, that the transition process is effective, that we also provide, for some groups, we provide a list once a month for their patients of where they are in the process. Are they in the referral process, evaluation, wait list? Are they on the list, or are they transplanted or post-transplant? We continue, just going back to Dr. Singh's note about dropout, patients who get referred then don't show up. We continue to follow with local labs and coordinators till the actual appointment happens. The transition doesn't happen till that first appointment with the nephrologist happen. For complications, complications are abound. If there is a transplant-related complication, we either take back ownership temporarily, or we co-manage. It depends really on the preference of the primary nephrologist. Some nephrologists are comfortable of adjusting cell set with BK. Some nephrologists are not. And I think the most important thing is really that personal connection. If you don't put the effort, we have to put effort as transplant centers to make connections with our referring base. If we don't put that effort, we're not this partnership is not going to work. So my cell phone, I think my cell phone, maybe 300-400 nephrologists have my cell phone. But it is, I think it's an effort that's worth it, and keep your hand on the pulse. Very important to have a multidisciplinary review process for the adverse events. That also includes potentially, if it does happen outside with an outside provider's care, to include that provider in the review process. And as in conclusion, and I'm sorry I took a little bit extra, I think early and effective transition can be done, but it does need work, it does need resources, and it does need will in the transplant center to make it happen because of the effort that comes with it, and adopt different workflows based on the need of the patients and referring practices. One size does not fit all. Leverage the virtual platform, set expectations early, and keep open lines of communications with referring practices, and careful evaluation of post-transplant outcomes with a root cause analysis process or a M&M process to adjust and allocate resources when needed. And thank you.